Hi, this is Dr. Amir Garakani. I am the chair of psychiatry and behavioral health at Greenwich Hospital. I'm also an assistant professor of clinical psychiatry at the Yale School of Medicine. I am very excited to be speaking about medication treatments for anxiety disorders. The title is Where We Are and Where We Are Going, and I'll explain a little bit more about that in a moment. I have no disclosures with any commercial interests or other conflicts of interest that are reportable at this time. So a little bit about the objectives. We're going to talk briefly about the biology of anxiety, and mainly just to give all of you a little bit of context about how anxiety occurs, how it manifests on a neurobiological level, and then talk about what's currently being used to treat anxiety. And this is something that many of you may already know about, what is approved and what's off-label, and then discuss medications that might have potential for treating anxiety in the future, and where we are in terms of medications on the pipeline. So just a little bit of humor. There was a movie called High Anxiety, which I think was a very funny movie by Mel Brooks, a spin-off of Vertigo, a spoof of Vertigo, and he plays a psychiatrist dealing with corruption at a psychiatric hospital. And I think it was a very funny movie involving the Psychoneurotic Institute for the very, very nervous and doctors forcing people to become ill. And I thought it was quite funny. But the reason I bring it up is the context of this movie is that the character played by Harvey Korman in the background, who looks like a werewolf, was actually causing patients to become sick so he can keep them there. And the thing I remember the last time I saw this movie was that as doctors, we try to help people. Of course, part of our Hippocratic oath is to do no harm. But sometimes in the course of physicians treating patients, and I just don't mean psychiatrists, I'm talking about patients, doctors in general treating patients, giving diagnoses of cancer or COVID, or telling someone they need surgery, or talking to families. Sometimes physicians, however well-meaning, might sometimes make people more anxious. And part of my job at Greenwich has been not just to help try to care for patients here and help the department grow, but part of it is also on educating my colleagues and helping them with patients who might be coming for treatment for cancer or heart disease or diabetes, young children coming for treatment, and helping them be better at what they do, and being collaborative and supportive. And that's sort of what we want to do at Greenwich Hospital, is grow into a place that continues to offer high quality care and expand what we can offer here. So on that note, I'd like to start by discussing what anxiety is. And I can tell you right now that anxiety and fear are commonly confused with one another. And just to be clear, there are similarities, and sometimes the terms are used interchangeably, but I want to give a little bit of distinction of what the difference is. Fear is a response to a known, definite, external, identifiable threat, whereas anxiety is a response to an unclear, internal, or vague threat. And the way I like to describe it is that someone who might have a fear of being on, say, the subway in New York, will, when they're on the subway, they're in a state of fear over the subway stopping underground and the lights going off, or a fear possibly of getting attacked or being crushed by crowds. But if that person is at their home and late at night and they're having a panic attack, it might be related to having to get on the subway the next day, that would be considered anxiety, because they're not actually under threat at that moment. They're simply existing in a state of anxiety. And the way I like to think about it is, and some people disagree perhaps with this, but I like to think of it in terms of dogs, for instance, animals. A dog might be fearful in a specific situation, but if you take the animal out of that situation, animals can still experience trauma, of course, as anybody knows, but and they might have fear responses outside of situations. But the reason that humans and all humans experience anxiety is that it's a warning system of danger. But anxiety if it persists, can also become maladaptive and make us suffer and cause disease. And we'll talk a little bit more about that. But just to give you a little background, this is me, and this is a little dog, Nanushka, who was, when we were living in New York when I was born, New York City, and this dog was a neighbor's dog, and she was quite Pekingese, quite an aggressive dog, and I was scared because she would bark, and I wouldn't say attack, but she was pretty menacing for what it looks like a very cute Pekingese. My parents are both in the mental health field. My father is a psychiatrist. My mother and father tried very hard to get me to not be afraid of the dog. And then I don't know if it was my mother or father who took this picture of me sitting next to her. And it sort of goes to show that even though this dog caused a lot of fear in me when I was very small, the older I got, the less afraid I became through exposure. So that's part of what I want to talk about, is that a lot of the work that we do for treating anxiety isn't just about medications, of course, but it's about exposing yourself, even if you've had negative experiences, whether it be with riding on the subway or with, furry little Pekingese dogs. So I'd like to talk a little bit about stress, though, and stress is different from anxiety in that it's basically physiological and psychological demands being put on the body, and stress was defined as by Lazarus and Folkman as a particular relationship between the person and the environment that is appraised by the person as taxing or exceeding his or her resources and endangering his or her well-being. So that isn't exactly like anxiety. It's sort of like repetitive anxiety. And the reason that this is important is because stress and anxiety go together. And as I mentioned, a fight or flight, which we can talk a little bit about in a moment, is sort of our body's alarm system. As you know, norepinephrine and epinephrine and norepinephrine, or adrenaline and noradrenaline, your body goes into a heightened stress response in order to deal with a frightening situation, like your apartment's on fire, or you're going to be attacked by a wild animal or something. But the problem is, if your body's in a constant state of stress, that's not healthy, and your body continues to try to fight the stress response by decreasing release of catecholamines, which are the compounds which are responsible for regulating mood, like dopamine and norepinephrine and serotonin. And so what happens is the body then switches to release the glucocorticoids, which are to help deal with the stress response. And the problem is that if that happens, then it starts to take a toll on your body. It reduces your immunity. It makes you more likely to become ill. And there are ways that you can test for that, but stress responses are definitely, causes of chronic disease, not just depression, but other types of diseases in children and adults. We've been seeing a lot of this, for instance, during COVID. People gaining weight, becoming more depressed and withdrawn, gaining a particular obesity in their trunk, heightened cortisol response. So helping to deal with anxiety and stress in a moment before it causes chronic responses is really vital. So anxiety can be either a here or now thing or a long-standing thing. There are people who just have anxious traits, people who are predisposed to having anxiety. And it could be situation dependent, either I'm afraid of crowds, heights, dogs, or it could be free-floating anxiety. And it could be psychological and or somatic, meaning it's in your head, or your anxiety response is I get nauseous and throw up. And of course, you can have both, and having both is quite common, actually. Worry, on the other hand, is something a little bit different. It's this kind of chain of thoughts that starts with somebody like it's like the equivalent of like taking a piece of thread in a sweater and just pulling it, and it keeps going and going. Whereas a person engages in an attempt to mentally problem solve an issue with an uncertain outcome, but there's a lot of possibilities of negative outcomes. And so it's related to a fear process. Worry, as I think of it, is like you trying to play chess against yourself in your mind. But anxiety and worry are sometimes used interchangeably. Worry, I think, is a more complex process that's going on a neurocognitive level. So a little bit about the biology of fear. I'm going to go through this quickly because there's really this is not really a neurobiology talk, but we have in our brains the amygdala, and the amygdala is sort of our fear system. And the amygdala is found in pretty much all animals, and animals who have fear responses can occur through a fear conditioning model. And it's sort of like the Pavlovian dog modeling, except not like ringing a bell and giving a piece of meat. It's more like ringing a loud noise and causing a fear response to noisy stimulations. And like pairing it, that's what's called operant conditioning. You can actually have an extinction of fear responses over time, as I talked about, like fear of animals or objects or situations can be extinguished with repetitive exposure without a bad outcome, a fearful outcome. It's similar to the effect of, like, if you have one bad experience with a dog, but then your next 20 experiences with the dogs which look and act like very similar will let you feel like, oh, maybe dogs aren't scary. You see increased amygdala activity in anxiety disorders, but it used to be thought that the amygdala was sort of the end-all be-all of what is our anxiety systems, but it actually turns out the prefrontal cortex is far more important than previously understood. And it's the area of the brain that makes humans so different than other animals, in that it's the most distinct and most developed part of our brains. And if you look at genetic mapping, the prefrontal cortex is the area of the brain that distinguishes us most genetically from our closest animals, which are chimpanzees. I mean, we share like 95% of our genetic material with chimpanzees, and that other 5%, most of it is accounted for by our highest brain functions, motor and higher, like, abstract reasoning types of functions. So this is the area of the brain that I think is so important, but it's also tied together with other areas of the brain, like the hippocampus, the thalamus, the insula. And as you can see, the way this happens is sort of a top-down effect. The prefrontal cortex is at the top, and then it trickles down to the areas of the brain that cause the physiological effects of anxiety and affect the serotonin, norepinephrine, dopamine, the autonomic system, which is the parasympathetic, sympathetic nervous system. That's what the autonomic is under the hypothalamus, the pituitary, the adrenal glands, which control the release of glucocorticoids. So just to give you a sense, this is very complex, but I just want to let everybody know that it's not as simple as like one area of the brain said, this is the area responsible for anxiety. No, it's the whole area, many areas of the brain are playing a part in an anxiety response or fear response. We don't have to go over this, but this is a more developed model of fear and anxiety by Joe Ledoux and Daniel Pine. Just a funny little anecdote. Joe Ledoux is at NYU, and he's an anxiety researcher, neurobiologist, and he has a band called the Amygdaloids. So he's a musician. And Dr. Pine works at the National Institute of Health, an expert in anxiety disorders, particularly in childhood development and childhood anxiety. But there's the references. And throughout the presentation, you'll see links to papers that I'm citing. So anxiety can occur with a lot of different disease processes, and that's something that's important to remember. You can have anxiety and depression. You can get people who are anxious in bipolar disorder, which causes a huge number of problems because the treatments, as I'll go over in a bit, can interact in negative ways with bipolar disorder. Giving people antidepressants, for instance, in bipolar disorder is risky because it can cause the person to switch or flip into a manic state. Schizophrenia, people can have anxiety as well. It can be mistaken for agitation. People with personality disorders can have both anxiety and personality, and they can both cause heightened emotions. Somatoform disorders, which are like disorders where people have a false sense of belief about their own illnesses and feeling that they have illnesses, like, for instance, what used to be called hypochondriasis is an example of a type of somatoform. ADHD, people can be hyperactive and be mistaken for being anxious, or you could have both. And then substance use disorders, again, I can recall I work at Greenwich Hospital. One of the things I do here in my clinical work is in the Addiction Recovery Center, and we work with a lot of patients who have, I mean, it's primarily substance use, but we work with a lot of patients who have anxiety, and treating anxiety in patients with substance use disorders is quite challenging because the medications that use to treat anxiety, like benzodiazepines, can be risky to give to somebody with history of drug and alcohol use. But we'll talk a little bit about benzodiazepines in a moment. Here are some things that you have to look out for. If someone's using cocaine, amphetamines, hallucinogens, cannabis, caffeine. I recall having a patient years ago when I worked at Silver Hill Hospital. She finished her recovery and did a rehab, and she continued to work with me privately in my office. And one day she came in and she was very jittery. And she says, "I don't know what's going on, Dr. Garakani. I'm still really anxious." And I looked in her bag and she had a bunch of cans of those energy drinks, about 3 cans of them. And I thought, oh boy, she's drinking a lot of those. And I told her, I said, caffeine back in the old days when, some of the pioneers of anxiety research, like Donald Klein from Columbia, the late Donald Klein, who developed one of the earliest models of panic, they used to use caffeine to induce anxiety in patients. And so it's not surprising that the caffeine can cause anxiety. It's not surprising that cocaine and amphetamines, like things like stimulants like Adderall and Ritalin and Vyvanse and Concerta, these are brand names of medications that you might be familiar with. Hallucinogens can, of course, cause that, and cannabis. I'll talk about that in a moment. And people going through withdrawal, someone who stops drinking or stops taking benzodiazepines or barbiturates or other sedative medications can experience anxiety. And in cases like that, that can be very dangerous because the person withdrawal could turn into a seizure. So you have to be very careful. But it's important for anybody who's seeking treatment to be aware that it's very difficult for any physicians, psychiatrists, therapists to treat patients who are actively using substances. Even nicotine, which I didn't include here, but nicotine is not a relaxant. It may cause your muscles to relax, but nicotine is actually a stimulant. So drugs can affect the body in ways that that will affect your ability to respond to medications and therapy. So just to be aware. Some other things that might cause, thyroid is the big one. I would say having thyroid disease undiagnosed could be a big factor that I've seen a lot. People also could have neurological diseases, strokes, for instance, migraines very commonly cause anxiety, infectious diseases like Lyme and like COVID. Well, I'm not going to talk much about it. Maybe someday soon I'll give a talk about COVID and its effects on the brain and body, but it can cause a heightened immune response and cause anxiety, depression, psychosis, a lot of different psychiatric manifestations. But we're still starting to understand little by little what COVID does to the body, so more on that soon. These are the anxiety disorders that I'm going to talk about, and I wanted to just make you aware of the abbreviations. PD is panic disorder. Agoraphobia used to be linked with panic disorder, but now it's considered a separate diagnosis. Agoraphobia refers to a fear of being in public places, agora from the Greek from marketplace, so fear of the marketplace. Specific phobias refer to any type of phobia to a specific trigger, whether it be blood, vomiting, heights, crowds, spiders, that's called arachnophobia, and then social anxiety disorder and generalized anxiety. I'll just tell you right now that there isn't a lot of research that's been done on treating agoraphobia separately or specific phobias. Most of the talk will focus on panic, social anxiety, and generalized anxiety disorder. That's just simply, going to be the primary crux of our discussion. This is important to point out. Some people will say, well, are you going to talk about PTSD or OCD, post-traumatic stress? So the reason I want to point this out is that this was a study that was in Science, which is a very big, very reputable journal, and it's part of a genetic mapping of different disorders. And what they found is that if you look at it, anxiety disorders and if you look at the genetic correlation, the links, anxiety disorders are actually not very strongly linked with either PTSD or OCD. Anxiety disorders actually have a much stronger link with major depressive disorder or depression. This is what prompted a lot of research to make obsessive compulsive disorder and PTSD or post-traumatic stress disorder separate diagnostic categories. So that's why I'm not going to talk about them, even though in the previous edition of the DSM, which is the Diagnostic Manual for Psychiatry, OCD and PTSD were put under anxiety disorders, but they are no longer. So the focus of this talk is not going to be about either of those, because as I said, those are entirely different topics upon themselves. So we're not going to discuss these other anxiety disorders, mainly because they're not really specific to work that we're doing. So separation anxiety and selective mutism are primarily childhood anxiety disorders, and as I said, we're not going to talk about children. We're just going to talk about adult anxiety here. I only want to point this out for the sake of helping people to understand why this is important. Anxiety disorders make up probably the largest portion of anxiety disorders, of psychiatric disorders. If you look at the total number, and again, this data is old. This data is from like the early part of the 2000s, and it's if you can see, it's from 2007 is when this study came out, but they haven't had more updated numbers. This is from Harvard and a group that did an epidemiologic work on the prevalence in the United States. So this is not worldwide. But as you can see, anxiety disorders, any of the anxiety disorders, they make up, and unfortunately this did include OCD and PTSD, but I think the point is still valid, 31.2% of lifetime prevalence, meaning in this country, people will be diagnosed with one of those disorders in their lifetime. And that is more common than mood disorders like depression, or impulse control disorders, or even substance use disorders, especially if you take out nicotine dependence, which in and of itself is highly common. I think it's worth noting that anxiety disorders are among the most common disorders in this country and potentially in the world. So as I said, they're very prevalent. Unfortunately, there are low numbers of patients who are seeking what I would call appropriate treatments, high rates of psychiatric disability. Depression still is the most disabling disorder in the world, not even including all medical disorders. Like the World Health Organization said, depression is the most disabling disease in the world. And putting aside medical, psychiatric, it's all the same. High cost of burden. The anxiety definitely is a big cause of work and school absences. And people who have anxiety have worse outcomes if they have other medical or psychiatric conditions, like heart disease or cancer, or whether they have depression. People with depression and anxiety have worse outcomes than people who just have depression alone. So this is why it's so relevant to treat anxiety. Here are the treatments: benzodiazepines, antidepressants of the different classes, which I'll go over, azapirones, I'll explain what those are, anticonvulsants, which are anti-seizure medications, antipsychotics, which the name is deceiving because they aren't just medications to treat psychosis, even though that's why they were developed, and then other medications. Then, of course, there's cognitive behavioral therapy, exposure therapy, different types of psychotherapies. And then, of course, you have medication plus psychotherapy, which is still considered a highly effective and probably the gold standard. Although there is some research showing that combining medication with therapy isn't always better than just one or the other. But for a lot of patients, that's the optimal choice for them. I'm not going to talk about behavioral therapies, not because they're not important, but because this focuses more on medications, given the limitations of time. But I hope we can have a talk more about psychotherapies and different behavioral therapies. So I can't talk about anxiety without talking about GABA. GABA is the inhibitory neurotransmitter for the brain. It's the area it's the transmitter that's responsible for relaxation in the body. It is it is actually synthesized from glutamate, which is the primary excitatory neurotransmitter of the body, which is, and glutamate is responsible for instance, the effects of medications like ketamine to treat depression. And we'll talk a little bit about that in a moment. But I just want to make people aware that GABA is, you might hear that there are compounds and over-the-counter herbal medications called GABA. They're basically working on this part of the brain. Benzodiazepines work as direct agonists, which means they work directly on the GABA A receptor. And what they do is they modulate the receptor and cause fast inhibitory neurotransmission, which means they cause a heightened inhibitory response, which is, say, a calming response. So let me talk a little bit about the history of benzodiazepines. They were developed back in the 1950s. Chlordiazepoxide or Librium was the first one developed, and they were very popular through the 60s and 70s. The Rolling Stones wrote about Mother's Little Helper, which was about diazepam or Valium, and they were basically the medication of choice for treating neurotic, anxious patients, even depressed people. They were the medication of choice for sleep, for calming, for agitation. The task force of the American Psychiatric Association had to respond, however, to heightened concerns about abuse of benzodiazepines. And this statement speaks to the fact that they say that it's common amongst people only who have a history of alcohol, opiate, or other drug abuse, and that giving benzodiazepines to them is more likely to be risky, but that they still feel that it's important to feel comfortable prescribing benzodiazepines to appropriate patients, and whatever, we'll talk more about that. But it's important to consider the risks. But this was an important moment in the field because there was definitely a dividing and a fracture between factions in psychiatry, where there are those who are very anti-benzodiazepine and those who are very pro. And everyone else was sort of caught in the middle, not sure what to do. They're still the most widely prescribed psychiatric medication class in the United States and in the world. Alprazolam, which also goes by the name Xanax, is the most widely prescribed benzodiazepine in this country. And benzodiazepines in general are primarily prescribed by primary care doctors. As I mentioned, psychiatry as a field over the last 20, 30 years, I graduated medical school coming up in May 20 years ago. And I can tell you that since I started my training, where I trained was Mount Sinai Hospital in New York, I could sense that there was a tidal shift where we were taught to avoid giving benzodiazepines if possible and move away from prescribing them. And in my subsequent work doing research in anxiety and mood disorders, in my research fellowship, I found that there was a lot of push to move away from benzodiazepines. And when I started my private practice, I suddenly realized like that I had become one of the doctors who had been sort of, I would say, scared off from them. But that doesn't mean they're not effective. But in the process of moving away from them, patients didn't move away. They just said, well, if I can't find a psychiatrist who'll give it to me, I'll go to my primary care doctor. And this creates a problem. If you look at this chart, you can see that benzodiazepines prescribing goes up dramatically over age, and women more so than men. This is not a good trend. Benzodiazepines should not be prescribed to elderly people because of their risks potentially to them in terms of falls and confusion, but they become more prevalent as people get older. But let me tell you a little bit about benzodiazepines. So they have the same structure, which means that their effects on the body are due to how your body metabolizes them, not so much about the basic dynamics of the medication themselves. Here are some of their clinical effects. They can have anti-anxiety effects. They can cause people to go to sleep. They can relax muscles. They're used by physicians as muscle relaxants for muscle spasms. They have anti-nausea effects. They're used as sedatives, including midazolam or Versed, which is used as a sedative for ECT and some surgical procedures, and can also be used for endoscopies as well. They have anti-seizure effects. In fact, they're Diazepam or Valium is commonly used to treat people who are in status epilepticus, which is like a persisting seizure. They can cause amnesia, which can be an effect that's either desired or not, but they can also potentially have links with cognitive impairment, although there was a recent study in 2020 that said that it's probably not likely that they're linked with dementia, although the study hasn't been replicated. There was previous research that said that benzodiazepines are linked with dementia. I think there's been some pushback against that, but they definitely in the short term can cause cognitive dulling and confusion, especially in older adults. And problems with ataxia, which is on the effects on the cerebellum, which is not surprising because they work in the same part of the brain as alcohol. So it's not surprising that they would cause that. Dry mouth, constipation, respiratory depression, meaning you can stop breathing. It's probably very unlikely that a person would be able to take their own life by overdosing on benzodiazepines alone, but if you combine it with barbiturates or alcohol, antihistamines, or most definitely with opioids. In fact, some of the largest numbers of deaths that we're seeing from opioid overdoses are in cases where people are combining opioids with either alcohol, benzodiazepines, or both. So it can suppress the breathing in your brain, and that's why people die. It's very scary, and this is one of the other reasons why benzodiazepines have to be monitored very carefully, especially in people who have substance use problems. Here are the indications. Generalized anxiety disorder. There's some people who feel they're actually more effective for treating generalized anxiety than SSRIs. Social anxiety, panic disorder. They're actually approved for treating panic disorder. In most cases now, doctors will give them with an SSRI early in treatment to help when patients have an initial response to the medications to help them come over the hump as the medications start to kick in. They're linked with effective responses for panic attacks and anxiety and no specific reason, like a person has a panic attack and they end up in an emergency room thinking they have a heart attack. Patient will respond very quickly to a dose of a benzodiazepine. They can be used to treat mania. Patients who have bipolar mania, who are very agitated, it's actually quite effective. They are helpful for insomnia with the understanding that people can become dependent on them, and they're not really long-term effective treatments for insomnia because they can reduce REM sleep, which is not good. They're definitely effective in treating alcohol withdrawal, and they're still the gold standard for treating people who are in alcohol withdrawal or benzodiazepine withdrawal. For catatonia, people who become catatonic, meaning they're in a frozen state, they're not talking or communicating, and that can be caused by psychosis or depression. Certain drugs can cause it. There are medical causes of catatonia as well. The first line treatment is to give high doses of benzodiazepines, and if that doesn't work, ECT, or what's commonly used to be known as shock therapy. They're used to treat REM sleep behavior disorders, which is where people act out their dreams. They're used for agitation, in emergency settings, and in seizures. Here are the medications: alprazolam, clonazepam, and the dose ranges. I'll let you know that all the information I'm presenting is available on the web. I have a paper where I wrote about all of this, and it has handouts in there and it has tables going over all of this. So don't feel like you have to write anything down. These are Xanax bars. These are the medications you might see on the streets. If any of you ever are in a situation where a family member or someone you care about has pills and you don't know what they are, obviously in this case, it's fairly obvious you would see that, but you can go to a website called drugs.com or some other websites and you can actually identify the pills so you'll know what they are. But these are very commonly sold on the street, especially to kind of counteract the effects of stimulants and other activating drugs. These are the footballs of the 1 milligrams. So benzodiazepines are Schedule 4, and I'll tell you right now what the scheduling system is. Schedule 1 are drugs that are not felt to have any medical use or indication, and no physician who's outside of very prescribed circumstances, like doing research or government work, can prescribe it. Schedule 2 through 5 are drugs that any doctor who has a DA number and has controlled substance prescribing privileges, which is probably most of the doctors that you'll encounter, whether it be surgeons, psychiatrists, internists, pediatricians, can prescribe this. And you have to have a federal DA number. Schedule 2 is the highest level of control. You can't give refills. There's a lot of monitoring. Benzodiazepines are Schedule 4, which is the second lowest. In some states like Connecticut, you can actually get refills on benzodiazepines, but not in New York. So it does vary from state to state. But the point is that if you're a physician and you want to prescribe the medications, you have to go through a prescribing database. And anytime you want a prescription for a benzodiazepine or an opioid or a stimulant, your doctor has to check the database and has to prescribe it electronically. In New York and Connecticut, all controlled meds have to go through an electronic prescription. So these are ways to prevent people from doctor shopping. You go to, Dr. Smith, and you're like, hey, I'm really anxious, and Dr. Smith gives you a prescription for clonazepam or alprazolam. And then you go to Dr. Jones, and you're like, can I get a prescription for this? And the doctor would just give you a prescription. But now that second doctor has to check the database first. So how do you take someone off benzodiazepines? Well, that can be tricky business. Short-acting medications like Xanax, you have to taper them using long-acting medications like clonazepam, and that can be done over 2 to 4 weeks, depending on how long they've been on it. They've been on it for years. It may take months to taper them off. And I wouldn't recommend doing a rapid taper because a person could have withdrawal, they could have seizures. But this is definitely something you should talk about with your doctor. And I would recommend getting off of a short-acting medication like Xanax or lorazepam or Ativan and switching to a longer-acting one like clonazepam. It's just safer. So some people feel benzodiazepines should be restricted, and then there are other people like Dr. Fava, Dr. Ballin, and I know Dr. Ballin, having read a lot of his work, who feel like this is taking a very effective and important class of medications and kind of shuffling them away. And I would say I agree with him, but I also understand the other perspective, which is that if you work in the field of addiction or you work with people who have become dependent on these medications, it is very difficult. So I think my recommendation would be, if you're feeling like you're anxious and your doctor gave you a prescription for benzodiazepines, and it's always worthwhile to talk to a psychiatrist. And that's part of the initiative of Greenwich Hospital, and our community work will be to try to make mental health providers available to the community so that people can get psychiatric evaluations and get put on appropriate treatments, which may be benzodiazepines. But so I would say that I've moved away from being so adamantly opposed to prescribing them, but I still think we need to use caution. So the recommendation of the American Psychiatric Association for panic and other anxiety disorders is cognitive therapy and other behavioral therapies. And that you would consider group therapy for some people, but that maybe combining medications with therapy is not effective. But for patients who want medications, I think that benzodiazepines would be one choice. But we'll talk about the other options in the current available treatments. So right now, SSRIs are probably the most commonly known and popular and most widely prescribed of the antidepressants, which are used to treat anxiety. Some of the things that they can cause: nausea, diarrhea, constipation, dizziness, headache, anxiety, paradoxically, and sexual dysfunction. I would say that the sexual dysfunction is probably the one that is the most durable, than the one that doesn't go away over time, and also most dependent on dose. SNRIs, which are a newer class of medication, which are usually used as a second line after you've tried SSRIs, have similar side effects, but they can also be more activating, making people sweat, raise your blood pressure. As I said, both of these medication classes are effective, but they take time to work. For SSRIs, up to 4 to 6 weeks before you'll see a response. Tricyclics are the older class. And these are the medications that were used before SSRIs, and they are quite effective. And I know that especially in neurological circles, these medications are very popular because they can be helpful for pain syndromes and for headache disorders, especially amitriptyline. But they have a lot of side effects. They can cause dry mouth, weight gain. They're also, unfortunately, potentially fatal in overdose, which is why they kind of fell out of favor in psychiatry, and why SSRIs kind of took the reins in terms of tricyclics. There are still people who take these medications, but they're not widely used, especially not as a first line. This is some information. As I said, this information is all available in my lecture handout, which I'll go over at the end. The article that you can find online. It's open access, meaning there won't be any fee for it. But these are some medications most of you probably heard of, like Prozac, Zoloft. These are the brand names, and then the generic names. All of these medications should be available as generics. It doesn't mean your insurance will necessarily cover some of the brand names, but as you can see, the one at the bottom, Luvox, is used mainly for OCD, but it can be used for any of the anxiety disorders. Because as I said, all of these work the same way. They just have different side effects. Like for instance, Paxil or paroxetine is more sedating and may cause more weight gain. But as I said, it is about preference. I'm not going to talk about genomic testing, where you get a swab in your mouth and it tells you how your metabolic system works. That's a whole other topic of discussion. But I think this is more about, the patient preference and what the doctor is comfortable prescribing. Here are the SNRIs, serotonin norepinephrine reuptake inhibitors, a little bit about them. These are all 3 medications. The one at the bottom, desvenlafaxine, I think it has gone generic, but it's the newest of them, and it may not be available to everybody in terms of the cost. Here are some other classes of medications, antipsychotics, and some of the names of the antipsychotic medications. I don't think that these are medications that should be considered until you've tried other options, because of the fact that these are medications that have a lot of potential risks or side effects. They're mainly approved for schizophrenia, bipolar disorder, agitation, in some cases to add on to the antidepressants for people with severe depression. They are not approved except for stelazine. None of them are approved for treating anxiety, but they are still used for anxiety. And if you look at some of the side effects, you can see it can seem quite scary. It doesn't mean I don't think these medications can be highly effective for people. It's just these are not things that I think should be taken lightly, because in my experience, the risks usually outweigh the benefits. And even though there is evidence for using quetiapine, which goes by the brand name Seroquel for generalized anxiety, there are concerns about potential risks. Now, the CANMAT is the Canadian guidelines. There is some recommendations on using different antipsychotics for different anxiety disorders, but they said it's further studies needed, which is what we're doing. So this group, which made up a few of my colleagues, including Dr. Raphael Friere, who's based out of Canada. The people listed at the top there are not all, they misspelled Dr. Perez's name, but they're not all the people who are working on this research. We're doing a review of how much data is there for using antipsychotics and anxiety. And this is currently under works, this research. We're doing a review of the literature to see how much there is available. So we'll get back to you about that. Things are still in process. Azapirones. So this is medication known as Buspar. You might know what Buspar is. It's used for anxiety. It acts on the 5-HT1, which is one of the serotonin receptors. It's more like a kind of a pinpoint to specific serotonin. It's meant to be taken daily. Sometimes patients come in and say, can I be put on something just to take whenever I have anxiety? This is not one of those medications. This is to be taken every day, usually in conjunction with an SSRI. Some people find it effective. In my experience, it can be effective if people can tolerate it. There are some effects of nausea, dizziness, headache. You have to be careful with using 2 medications that have serotonin effects, because they can have a compound effect and cause something called the serotonin syndrome, which is where a person can get muscle jerks, spasms, seizures. It could be a medical emergency. I think buspirone is a good option for anxiety, but for people who have taken benzodiazepines before, probably not going to help them that much. This is a little bit kind of a messy, complicated thing, but the purpose of that is to show that Lyrica or pregabalin is a medication which is approved for treating nerve pain and fibromyalgia, but in Europe, it is actually approved for treating generalized anxiety disorder. In this country, it is not. And I'll go over that a little bit, but it is a Schedule 5 drug, meaning it's still listed as a controlled medication. And there is evidence of misuse and abuse. So there are risks to taking this medication, but it's something that sort of was initially developed for nerve pain and for seizures, but was found to potentially help anxiety. As I said, it was approved for anxiety in Europe. Pfizer tried to get approval here, but withdrew the application in 2010. It's a newer version of a medication called gabapentin or Neurontin, which some of you may have heard of. But it's more bioavailable, meaning that if you take it, it's absorbed more into the body than gabapentin, which tends to get lost in terms of like, if you take it, only 40% of it gets absorbed into your body. The other 60% get excreted. Pregabalin also isn't covered by insurance in certain cases, especially if you're taking it for anxiety. It has to be approved for a specific reason. But gabapentin or Neurontin is generic and it is widely available. It's not approved for any indication other than neuralgia or nerve pain or partial seizures. But what I found is that it has been widely prescribed for a lot of other things. They did a lot of research early on using it for anxiety and for mood disorders and depression, and most of the research didn't pan out. Pfizer got sued because there were allegations that it was marketing it for these non-indicated reasons. Nowadays, it gets used for a lot of different things, including alcohol withdrawal, alcohol cravings, cannabis cravings, anxiety. It has been studied in several trials for anxiety. And in my personal clinical experience, it definitely has utility, despite the lack of evidence. You would give it 2 to 4 times a day. It's short acting. It wears off after a few hours. It comes in 100 milligram capsules, 300 milligram capsules, 400 milligram capsules, 600 milligram tabs. And you can give multiple times a day, high doses. Renally excreted means comes out of the kidneys. So it's not a bad choice for someone who has liver disease. It can cause dry mouth, constipation, weight gain, swelling of the ankles. It also people can become dependent on it, and not in the same way that you can with benzodiazepines, but you still should taper off of it. There is abuse potential. You have to be really careful. Patients with addictions may not be able to take it because of the fact, if you have patients who are in drug court, some of you who have legal reasons which you're in treatment, they may not allow it. But all things being equal, I would say that if you have to choose between gabapentin or benzodiazepines for short-term use, gabapentin might be a more favorable option than a person, especially with a substance use problem. But you get to the point of, well, why are people taking medications to cope? Well, that's a whole other discussion. Other medications that can be used on a standing basis to treat anxiety, mirtazapine or Remeron, there's limited study. It might be helpful if you use it in conjunction with other antidepressants. Nefazodone, limited efficacy. It can damage the liver. And MAOIs are monoamine oxidase inhibitors. They're for people with very resistant cases of depression and anxiety. There's a lot of dietary restrictions one has to go on, like cutting out hard cheeses and like cured meats. And there are a lot of side effects, so they tend to be kind of a last resort option. Bupropion or Wellbutrin, approved for depression, ADHD, smoking, comes as Wellbutrin, Wellbutrin SR, and Wellbutrin XL, extended release. It is mainly approved as an antidepressant, but it's been used in certain cases for anxiety. And the reason some doctors prefer it is because it doesn't have some of the sexual side effects or weight gain side effects. And at low doses, it might actually help people's anxiety, but It may not increase anxiety initially, but for some patients, it can make them more activated. So it's not exactly because it works on dopamine, it may not be a great choice because it has stimulant effects. So, but something that could be used in small doses. Antihistamines, well, these are a wide range of medications: hydroxyzine, Vistaril, Atarax. Benadryl is considered an antihistamine. They can be used as needed for anxiety. They're not addicting, but people can become tolerant to them, and they can cause all the things that antihistamines can and make people tired. Propranolol might be effective for more performance anxiety and social anxiety, but there's lack of research support for it. And they are blood pressure medications, so you have to be careful. It can bottom people out, cause exercise intolerance. Same thing with clonidine. It can really lower your blood pressure dramatically and make people really tired. It's been used for anxiety, but there's limited evidence. It's primarily used to treat blood pressure, opioid withdrawal, and in some cases ADHD in children. But it's a pretty potent medication that has to be used with caution because, as I said, it can lower your blood pressure quite dramatically. So what are some strategies? Well, recommendations when you start with an antidepressant, let's say you want to start someone on an SSRI like, say, escitalopram, which goes by the name Lexapro. You start at a low dose, 5 milligrams a day or so, and you go really slow, a week, 2 weeks at the lowest possible dose, and then go up little by little, incremental doses. You may need to add on a benzodiazepine, preferably clonazepam. I would avoid alprazolam or Xanax, even though people like it, because it wears off, and that can cause rebound anxiety. You may need to give people higher doses, interestingly enough, of these medications to treat anxiety than you would for depression, and treat them for longer because anxiety tends to be harder to treat. Patients need to be aware of that. You might need to be on medications for at least a year, maybe more. Here are some of the newer treatments. We're going to go through this quickly. Serotonin medications, glutamate, GABA, which are neurosteroids, neuropeptides, cannabis, natural remedies. Here are some newer antidepressants on the market, vilazodone or Vibrid. It works similar to the SSRIs and to buspirone. It's approved for depression, and even though there were some studies in other anxiety disorders, it hasn't been approved for those. And it is an option to consider for somebody who has anxiety disorders, who you tried other antidepressants. But as I said, I would exercise caution with asking your doctor for it or seeking treatment because it's still fairly new. It's still being studied. Trintellix, there was some research promise for generalized anxiety, but the company didn't seek approval because there were some disappointing analyses done. But it's another newer medication. Problem with these newer medications is the cost considerations. They're quite expensive, and they're not available as generics. So your doctor might not be able to get the approval, and you'll have a large out-of-pocket cost. Azapirones, there are some newer azapirones, but these are mainly studied abroad. Buspirone is the only one that's approved in this country. Agomelatine, which was a melatonin agonist and a serotonin antagonist, was studied for depression, and it has really good evidence for generalized anxiety. But the issue is this medication is not approved in the U.S., but I've done a lot of reading about it, and it's an interesting medication, and it's certainly, I'm not sure why it's not available here in this country. But, I want to talk for a moment about hallucinogens, because I'm sure this is a huge topic of interest. Psilocybin has become like the hot trend. So what is it about psilocybin that's so interesting? Well, it's a Schedule I drug, meaning that like cannabis is not available by a prescription and doctors can't prescribe it. But it is being studied under very strict circumstances for treating anxiety and life-threatening diseases like cancer. And there are ongoing trials taking place. Also in OCD, there's going to be research coming next year on using psilocybin-assisted psychotherapy for treating different psychiatric disorders, including anxiety. But it's not going to be until next year or so. So we probably won't see full-scale research going on for at least a couple of years. So stay tuned. I happen to believe that there is a lot of promise in using hallucinogens, but only in the way that you would use them with other hallucinogenic agents, which is with assisted therapy in a controlled setting with like a doctor or nurse in a hospital or clinic setting. Very controlled setting, not just here's some magic mushrooms and go home kind of thing. You wouldn't want to do that. It would be very controlled. MDMA, same thing. There is actually recruitment going on next year for a study in social anxiety, but it's going to be therapy assisted treatment. Ketamine. Ketamine is already approved. Ketamine is probably one of the most interesting, novel treatment developments of the last 20 years. It was already being investigated many years ago for potential for the helping for psychiatric disorders. It was initially used as a model for psychosis, but ketamine has been around in medicine for anesthetic reasons. It's used as a veterinary anesthetic, and for children with anesthesia. And they found that it had pain relieving effects. So it is being used in headache and pain clinics by anesthesiologists. But because of its effect on glutamate, it was found to potentially help depression. So extensive study was done. I was involved in some of the clinical trials back in the mid-2000s when I was a trainee at Mount Sinai. And it did finally gain approval as an intranasal form, Spravato. I don't have any relationship with the company or with this. I left before I could get involved in any of that. But it is remarkable and that we've developed a novel approach other than serotonin to treat depression. Now there's some research going on and using it in post-traumatic stress, which is promising. There was some research done with a group at Yale on social anxiety, but there hasn't been any new research, but I think there is a lot of promise and potential. And stay tuned, but there should be some interesting things coming with ketamine. D-cycloserine is an older medication that was used for augmentation of exposure therapy. You would give it to someone while they're getting exposure therapy for a specific phobia, like a fear of spiders or a fear of heights. And there was a lot of research done on it, but large-scale studies and meta-analyses have shown that the data is not that promising. So it's kind of fizzled out, so to speak. Nitrous oxide. The reason I bring this up is that I actually was involved in a review of the toxicity of nitrous oxide and nitrous oxide abuse. This is a medication. This is an anesthetic, an inhaled anesthetic, which is used, as you may know, in dental procedures. But it's also potentially abusable, not just by dentists, but by general public. What you see in this picture are like whippet bulbs, which are used for canisters for food, for making like whipped cream. It can cause a lot of toxicity, nerve damage, spinal cord paralysis, death. It can cause psychosis and mania and depression. It lowers your vitamin B12 levels. So not exactly something you think would be effective for treating anxiety, but there is research in PTSD and in depression, potential effects of nitrous oxide. But this is one of those things that's going to take some time and some convincing to get people to buy into it. Very much like the way ketamine did and still does. Mifepristone, really interesting. Might be known as an abortion pill, but it also has been shown to help in PTSD. But it was just one study, and there's some pilot data on anxiety, cognitive dysfunction. So there's some potential there with using neurosteroids, which work on the GABA system. I find it more interesting with this PH94B, which is an inhaled neurosteroid, which is used for acute treatment in social anxiety, giving it before an exposure to public speaking, similar to how propranolol might be used. I'm not sure what's going on with it in terms of like FDA or further research, but there were 2 studies that came out in the last, I think, 10 years or so, 5-10 years. But I think it's exciting, and I'm looking forward to finding out more about it. Neuropeptides. We'll talk a little bit about oxytocin. Oxytocin is known as the love hormone. It's involved in attachment, social bonding. High levels are released during childbirth and involved in bonding between mother and child. Interestingly, the findings are that Oxytocin gets released when you look at your child, or if an adult looks at a dog, the dog's brain and the human's brain both release oxytocin. So it is about attachment and bonding. Research has found lower levels in patients with autism and schizophrenia where there are social deficits. So potential for use in those disorders. Can you give it to patients, in a form that they might be able to absorb, nasally, through a spray, or possibly under the tongue? Just as an emphasis of full disclosure, Dr. Rocco Murata at Silver Hill and I have been involved in some research on using the sublingual form, which means that it goes on the tongue, it gets absorbed directly into the bloodstream, in treating patients with schizophrenia who are also taking clozapine, which is an antipsychotic. I think there's still, a lot of potential here, but more research needs to be done. I don't have much to say about these other neuropeptides, just to sort of move on. Orexin, or Belsomra, which is suvorexant, which is a sleep aid, which is used for insomnia. It's under study for panic, but this is a medication which is used mainly as a sleep aid, and there's kind of limited, potential there, but it's just something to keep an eye on. Cannabinoids. So this is something I'd like to talk about for a little bit. Marijuana. Cannabinoids are one of the components of marijuana. As I said, it's Schedule 1. Even though it's medicalized across the US and many states are passing legalization, decriminalization, it still hasn't been studied on a larger scale. Even though medical clinics throughout the country in states where it's legalized for medical use are marketing it for trauma, PTSD. Here in Connecticut, you can find people prescribing medical marijuana and find dispensaries throughout the state. But this has not been studied on a large scale in randomized placebo-controlled studies to the extent where I think you can say with great certainty that it's safe or effective to use it for these indications. And the problem is you can't consistently deliver drugs through a smoking, through a vape, or through a cigarette. And there's questions about purity, even with medical uses. It is approved for use in cases of pain and spasticity, and there's good research support for that, but less for use in seizures and nausea and vomiting. But those are potential beneficial uses where there is a lot of research. So what is marijuana? Well, there's CBD and THC, the primary component. CBD, cannabidiol, is probably the most studied for anxiety. It can, in smaller studies, been shown to have effectiveness in treating anxiety. It's also found in many over-the-counter supplements and foods that you don't need a prescription to buy it. You can buy it at various health food supply stores. They usually advertise it in the window. But we'll talk about that in a minute. And then delta-9 tetrahydrocannabidiol, or THC, is probably the reason I think that we should have a lot of concern about the marijuana legalization movement, because it's a very potent compound. It's been linked with paranoia, psychosis. It can worsen anxiety, and the research on that is pretty clear. The marijuana of the current generation is definitely not the same marijuana of your parents' generation from the 60s. This is higher THC, more potent, higher links to schizophrenia and psychotic illnesses and cognitive problems. And it's definitely something that we need to be careful about. The researchers up at Yale and Dr. Deepak Cheryl D'Souza's group have shown a link between cannabis use and psychosis, including a 6-fold increase in schizophrenia diagnoses for teenagers who start during their mid-teens using marijuana consistently. So I think it's something that we have to be careful about because it's not entirely safe, so to speak. CBD is available in a lot of, Bed Bath & Beyond and other stores. And I don't know why someone would want a CBD-infused cotton pillowcase, but so be it. Or, creams or other types of things. But I would just exercise caution. CBD, even though people say it's not psychoactive, or it is psychoactive, what does it mean? So what does it mean? Yes, CBT is psychoactive. If a person tells you in an ad on one of your podcasts or somewhere that CBD is not psychoactive, but THC is, or delta 8 THC, which is a sister compound to delta 9, is safer, I would just point out that after they tell you it's not psychoactive, and then they say they want to use it for anxiety or PTSD or sleep. Well, if it's not psychoactive, well, how would it help anxiety or sleep? You can't have it both ways. Either it's psychoactive, which means it works on the psychological system or the brain systems which affect psychological function, or it doesn't. So under that definition, yes, it is psychoactive. And that means it can cause, positive and negative psychological effects, including confusion, fogginess, memory impairment, impaired motor skills, including, your ability to drive or, operate machinery. So just something to keep in mind. There are natural remedies as well, just a few things to keep in the back of your mind. Kava is probably the one that's most studied and potentially has the most benefit, but there's risks of liver toxicity. It's sort of equivocal how much kava can help. I know there's a lot of interest in herbal medications. Here are some other ones. L-theanine, which has been touted as a potential ashwagandha, lavender, chamomile, passion flower, valerian, which I would caution people using because valerian does have a very similar effect to benzodiazepines and could definitely cause similar effects to benzodiazepines, even though it's a legal form. Echinacea, saffron, which there was some research on saffron supplementation for anxiety and for depression. My family are from Iran, and we've known about the beneficial effects of saffron for generations. So I'm interested that everyone suddenly become interested in saffron and turmeric and other things of that nature. This is a paper that we wrote, and if you can see at the bottom, this is the link to the paper. It's in the Frontiers in Psychiatry. You can download it. This is not up to date. It's been viewed and downloaded a great deal since I made this slide, and I'm really excited about the research that we've done. It's a review paper, but I'm hoping it'll stimulate discussion and prompt further people to do more research. But I have to say I'm a little disappointed because the original review we did in 2014, there wasn't a lot of difference. When we wrote that original review, we didn't include some information about marijuana, and we didn't have a lot of information about some of these newer antidepressants, but the studies and the discussion were very much the same. I could have basically taken that original paper, copied it forward. I didn't do that. We rewrote the whole thing, but we could have done that and it wouldn't have changed that much, which is discouraging because in 6 years, you would hope the field would have advanced further. But there are few, if any, new medications available. So I think that we need to continue to look at new pathways like glutamate drugs, phytochemicals, which are herbal medications, neurosteroids, and yes, psychedelics. I know people are scared about the idea of hallucinogens and things that might work on the brain and cause those type of responses. But I think that there is a lot of untapped potential there. I think we should continue to use our standbys for now, but the hope is to expand beyond these norepinephrine, serotonin, and GABA pathways. I think we need to increase access to non-pharmacological treatments like CBT, cognitive behavioral therapy, and exposure therapy, including therapy-assisted medications. And I think we need to increase access to psychiatric care. And I don't mean this in a derogatory way towards primary care providers, but I don't think that patients should have to only rely on primary care specialists for prescribing and for managing people. We need to do better. And that's part of that's kind of the mission of our department going forward and of this community as a whole, is to improve access to psychiatric care and make ourselves available. Thank you for listening. I'm available for any questions any of you might have, and I hope there'll be first of many talks, and that we'll have an opportunity to get to meet some of you in the community, hopefully at a point where we are able to be up and running with our mood and anxiety programs, which we're looking to develop and expand upon in the coming months to years. Thank you very much.